Hello, everyone. I'm Vidya Sivaraman. I'm a pediatric rheumatologist at Nationwide Children's Hospital in Columbus, Ohio. And I'm very excited today to welcome Dr. Marc Foca from the Children's Hospital at Montefiore at the Albert Einstein College of Medicine. Dr. Foca is going to be talking about COVID-19 for the immunocompromised patient in 2022. So welcome, Dr. Foca. Thank you for speaking to us today.
Thank you. I hope everyone's having a good afternoon. So I'm going to try to go over a, a broad array of issues with COVID-19, starting from the beginning. I'm going to give a little background on COVID-19 in relation to other coronaviruses. Then I'll speak to the presentation of pediatric patients in general with COVID-19. And then I'll move on to the immunocompromised host, including some studies in pediatric rheumatology patients, and then finally with some prophylaxis and therapeutics at the end. So coronaviruses are RNA viruses, which are generally speaking the smallest viruses that can affect humans. They are zoonoses, which means that they are acquired from other animals, in this case, bats and camels and occasionally cattle. In children, they tend to have respiratory and GI effects, which are not the norm, generally speaking, for respiratory viruses. They're seasonal spread. And there are a few novel agents. The first would be SARS-CoV-1, which happened in 2002, 2003. Then Middle East respiratory virus, and finally SARS-CoV-2 or COVID-19. And this electron micrograph just shows you a typical coronavirus and how it got its name, which is these now infamous spike proteins, which look like a corona or crown. So generally speaking, there are four types of coronavirus that we see seasonally. It says here my slides are not advancing. Let's see. They're advancing for me. Is there some, let's see. Do you see them now? Okay, perfect. So this is the slide I spoke of before. This is what a coronavirus looks like in an electron microscope and how it got its name. And so these four coronaviruses are the ones we typically see during the fall and winter months. It turns out that there was an episode that was called the Russian flu in the late 1800s, which was probably one of these coronaviruses as it first entered the human population and caused a great deal of illness and mortality. But these are the four we typically see, and they're picked up on a normal respiratory panel that you or your child might get in the emergency room or in the hospital. And then we have the three special coronaviruses, the severe acute respiratory syndrome 1, COVID-19, and MERS. And what's interesting about these is that SARS-CoV-1, there were only about 8,000 cases in total before the disease vanished. And this is probably because patients were not they could not transmit before they were symptomatic. And so it was easy to isolate people and prevent transmission to other individuals. Whereas uh, COVID-19 is transmitted in patients who are asymptomatic, and so it's much more difficult to control spread. MERS is difficult to spread naturally, and so there are really only sporadic cases. So when you compare the original epidemic coronaviruses, SARS-CoV-1 to MERS, there was a 10% mortality with SARS-CoV-1 and 50% mortality in patients who were over 60 years of age. And there was definitely person-to-person spread. In early super spreader events, if you remember, we talked about super spreader events in the beginning of the pandemic. Um, there was quite a bit of transmission. And just for reference, measles, which we think is one of the most highly transmissible viruses ever known, has an R0 of about 18 to 20, which means that one individual can infect 18 to 20 other individuals. So these early super spreader events can transmit about as well as measles virus. Subsequent spread is much lower, and there have been no cases of SARS-CoV-1 since 2003. Again, for MERS, mortality is quite high, 30% overall, 50% in those over 60. And you can see that there is, again, subsequent spread is pretty low, and there's really very low level transmission, probably due to contact with the reservoir, which is the camel. For children, there are far fewer cases really to discuss. So the original SARS outbreak, there were only case series with 41 patients. The children had much milder disease and there was no mortality. If chest imaging was done, you could see abnormalities for months after infection, and there was no mother-to-child or vertical transmission of this infection. For MERS, there was a very large case series of respiratory viruses in children in Saudi Arabia after MERS was first identified, and there were no MERS infections in this group of over 2,000 children. And then there was a small case series of 38 children, almost half of whom were asymptomatic. And with this particular coronavirus, there was evidence of fetal demise. So you can see that SARS-CoV-2 sort of melds some of the patterns of both of these epidemic and seasonal coronaviruses. So the lessons learned from these outbreaks, which really could have informed us in the beginning of what was happening in 2020, is that in adults, these viruses cause respiratory failure, kidney injury, and there was very high mortality in those over 60 years of age with comorbidities like hypertension and diabetes. And person-to-person spread was quite effective, at least initially. In children, there appeared to be less severe disease, lower mortality. GI symptoms were quite common, so diarrhea and abdominal pain were quite common. And there was little to no evidence of transmission in utero. So this is the epidemic curve in the United States over the past several years. And all these slides that I'm going to be presenting now are from the CDC. They're only a few days old, so they're quite up to date. And you can see that this is the early in 2020 when most of the cases were on the East Coast. This was the winter of 2020 with the Alpha variant. We then went to the Delta variant and then Omicron, for which there have been a lot more cases. And now this sort of lower level transmission of Omicron variants throughout the country. And in pediatric patients, it largely mimics this curve. So this is pediatric cases overall by ethnicity. And the gray bars are the percentage of the total population, and the maroon bars are the percentage of cases. And so you can see that there are a larger number of cases in the Hispanic community and pediatric patients than is their percentage of the population. There's a smaller percentage in the white non-Hispanic population, and then the others are the number of cases are close to commensurate with their percentage of the overall population. In terms of mortality, again, the gray bars are overall percentage of the population, and the blue bars is mortality. And you can see that mortality is greater in Hispanic and the Black community than it is for their percentage of the population, and it's lower in the white and Asian communities. When we look at cases by age, looking at the overall population, you can see, and gray again is the percentage of the U.S. population. Maroon is the percentage of cases. You can see that children are lower represented than their percentage of the population, and older adolescents and young adults are a greater percentage than their population. Everybody else is pretty much congruent. And when you look at mortality by age, you can see quite a difference, right? So mortality in those over 60 increases sort of exponentially over their percentage of the population versus mortality in children, which is much, much lower than their population. And this is just a numerical view of that. So you can see that as of the beginning of this week, there were about 2,000 deaths in the age range of birth to 17 years of age, and that is far, far lower than the mortality seen in older age groups. But I would caveat this with the thought that in a bad influenza season, 100 pediatric deaths is considered a lot of mortality. And so 2,000 deaths over the past 2 years is about at least 10 times the mortality that we see in a normal influenza season. So I'm going to go over a little data now, just general data for hospitalized children with COVID-19. And this was something called the Tri-State Consortium, which was put together by my boss, Betsy Harold, at Montefiore. It looked at patients from Connecticut, New Jersey, and New York who had COVID-19 and were admitted. And this was early. This was in the pre-vaccine portion of the pandemic, so before the winter of 2020. This is a slightly busy slide, but the main points are that the younger age group was more likely to be admitted to the hospital, as were children who were overweight, children who had a higher white count were admitted more often, and who had a lower oxygen saturation in the emergency room, and infiltrates on their chest x-ray. So if you had a high white count and respiratory symptoms, including infiltrates and a low oxygen saturation, you were more likely to be admitted, and if you were younger and more overweight. And this tracked pretty well with what was seen with adult studies. So what happens in immunocompromised patients? So this was an early look at our group. I spend most of my time caring for patients who've had solid and liquid transplants. And so we looked at our solid organ patients, a little over 100 patients. This was also early in the pandemic. 22 of those patients were COVID positive, either by PCR or antibody testing. And so this was early enough that nobody was vaccinated. So if you were COVID positive by antibody, you had COVID, 19 at that point. And of that group of 22, only one was hospitalized. It was a 1-year-old who had had a liver transplant 3 months before the admission, and there were concerns for bacterial infection of the blood, of what we call sepsis. And so that patient was admitted but was discharged 2 days later, never requiring oxygen. And the vast majority of these 22 patients never realized that they had been sick. So a large percentage of our transplant population at that point had been infected with SARS-CoV-2, but most were asymptomatic, and there was no mortality and only one admission. And this was sort of borne out in other cohorts that people looked at. So what about patients with active rheumatologic disease? So this is a single center study, retrospective, so looking back at a clinic in Turkey, and they screened over 4,000 pediatric patients with rheumatologic disease. They found, again, this was also early in the pandemic, they found 87 who had evidence of prior COVID infection. 56 of those patients were hospitalized, and 31 were followed as outpatients. For our purposes, we're going to be looking at the patients, the 74 patients who had evidence of respiratory disease, not the patients with what's known as multisystem inflammatory syndrome of children, which could be an entire lecture unto itself. And so when they looked at these patients, they split them up into patients who were receiving biologic treatment and those who were not receiving biological treatment. And you can see that those receiving biologic treatment had a wide range of modifiers being used, from TNF inhibitors to anti-IL-1 and anti-IL-6 inhibitors. And they really found no difference in severity of disease or admission to the hospital in this group. And there was also no real difference in the types of laboratory abnormalities that they found. So the percentages of patients with increased CRP, a measure of inflammation, the percentage of patients with low lymphocyte counts, and other measures of inflammation like a high ferritin or an increased D-dimer. So the cohort was relatively small, but they found really no differences in those who were on biological modifiers versus not on biological modifiers. And then this study, also a single center study, looked at patients from Atlanta, again early in the pandemic. And what they found was they had 55 patients in total, 10 of whom were hospitalized, 45 who remained as outpatients. And in terms of demographics, you were more likely to be hospitalized if you were African American, and you were less likely to be hospitalized if you were Caucasian or white. And if you looked at their baseline rheumatologic disorders, there was really there was no difference in the types of illnesses, and there was only one patient in this cohort that had scleroderma. The difference was you were more likely to be admitted if you had active rheumatic disease, meaning your disease was not under control, despite the number of agents, and we'll see that in the next slide. So patients were more likely to be admitted if they were on high-dose steroids, greater than 10 milligrams of prednisone or prednisolone a day. They were also more likely to be admitted if they were on mycophenolate. They were more likely to be admitted if they were on rituximab therapy, and if they were severely immunosuppressed, meaning they were on more than one agent. Those patients who were on TNF inhibitors were actually less likely to be admitted. So again, this is a single center study. a small number of patients and offers possibly a glimpse of risk factors for admission, most of which appear to be similar to risk factors for the general pediatric population, but maybe a signal that there is some difference between patients depending upon their immunosuppressive therapy. So this final study is a very large look at children with pre-existing rheumatic and musculoskeletal disease. It used some databases that looked at countries throughout the world. It was 600 patients. It was not only pediatric, but it was also adult patients as well. But this had 600 pediatric patients from 25 countries. There was a 7% rate of hospitalization, and there were 3 deaths in this cohort of 600 patients. So relatively low mortality and a relatively low rate of hospitalization. And in the same cohort of adults with rheumatic disease, there was 50% mortality. And that's a general theme. All of the adult studies that I looked at prior to this talk had much, much higher mortality in their patients. And that could be because they already had pre-existing comorbidities, hypertension, heart disease, diabetes, either as a result of their rheumatic disease or in addition to their rheumatic disease. So mortality in the adult population is much, much higher. And so these were the factors that were found to be significant in terms of hospitalization. So patients with lupus and other vasculitic syndromes were more likely to be admitted to the hospital, and they used juvenile arthritis as the comparator. So that would have been an odds ratio of 1 for being admitted to the hospital. And so you can see that patients with lupus and other vasculitic syndromes were 4.3-fold more likely when they looked at multiple variables at the same time. Those with autoinflammatory syndromes were also more likely to be admitted to the hospital, and those who were overweight. And then, interestingly, when they looked at disease-modifying drugs, they did not see any indication that the disease-modifying drug being used resulted in greater admission. So it was really the type of disease, and if you were overweight, those were really the significant factors for admission. And if you remember from the previous study, it could be that these patients were under less control. And so we get to prophylaxis. So at this stage, our the regimens that we can use to prophylax and treat patients are much, much better than they were in 2020 and 2021. And so the number of children who are admitted to the hospital with active COVID should be relatively low and really should be based on disease activity and morbidity, overall comorbidities. And so vaccination is really the heart of the matter of prophylaxis for our patients. Vaccine can be given to virtually all children from 6 months of age onward. This is the Pfizer schedule, and I really urge you to speak not only with your pediatrician, but if you want to get in contact with an infectious disease physician at the institution where you see your rheumatologist, you should do so. This is the schedule for Pfizer vaccine, RNA vaccine for ages 5 to 11. You can see their primary series is a 3-dose series, or should be a 3-dose series, 3 weeks apart between the first and second dose, and then at least 4 weeks for the next dose. And then now with the new bivalent booster, that should be given at least 2 months after this third dose. So all children 5 and up should be getting a fourth booster dose at this point. Under 5, there's no recommendation for this dose yet, but there may be in the future. And you can see for Pfizer, if you're 6 months to 4 years, you get the 3 doses, and that's the end. For Moderna, Their dosing schedule is a little bit different than Pfizer, and their dosing schedule this way goes to 5 years. They do not have a booster, so if your children are 5 years old and they've received Moderna vaccine, in order to get the booster, they'll have to be boosted with the Pfizer product. If they're under 5, then they only get the 3 doses. 6 to 11 years is relatively similar to Pfizer. And when you go to 12 to 17, again, it's 4 doses. And then if you're 18 and older, you can actually choose a different product known as Novavax. And so this is a more traditional protein-based vaccine. It's a 3-dose primary series. It's actually their third dose is being updated to be bivalent to include Omicron variants. And so if you're less likely to be amenable to receiving an RNA vaccine, if you're 18 years and older, you can try to get Novavax. Quite effective. So that's vaccination, and really, children should be vaccinated no matter the immunosuppressive regimen that they're on. We know that those on greater immunosuppression are less likely to respond, but they may produce enough vaccine in the short term to prevent infection, and it's really in the longer term that they might have less protection than somebody who's not receiving immunosuppressive medications. There's no contraindication to receiving any of these vaccines due to your immunosuppressive regimen. So that's important to remember. The other product that can be used for prophylaxis is called Evusheld. This is only approved for patients who are 12 and older. It's a monoclonal antibody. It lasts for 6 months, and patients who remain on immunosuppression can receive this product every 6 months. It continues to have activity against Omicron variants, and that's checked periodically as new variants are recognized. And it can be used in situations where you're pretty sure that the immune response to vaccine will be suboptimal. And that's really, in this situation, patients who are on chronic rituximab therapy, where we know their B cells are low to absent, and they're unlikely to make antibody. So this has been quite helpful in some of our transplant patients who are receiving rituximab, and in those stem cell transplant patients who have low B cells for the first 6 months or so after they've been transplanted. In terms of treatment, and this is the last slide I have to really go over with you all today. There are multiple options at this point. The greatest number of options is for those who are 12 and over and who weigh at least 40 kilos, so close to 90 pounds. The first is the drug Paxlovid, which is 2 medications taken together for 5 days. If your child is old enough to receive this medication, you would just have to go over it with your rheumatologist in order to make sure that there's no interaction with other medications that your child is taking. One of the medications in this drug, ritonavir, can inhibit enzymes that are involved in metabolism of certain medications, so it's important to go over this before it's prescribed. You can give, there's another monoclonal antibody that can be given for treatment, not for prevention. It's called bebletivimab, and again, for those 12 and over. And while there's no specific evidence for or against it, we have certainly used it in adolescents as therapy for their breakthrough COVID infection. And then for those who are admitted to the hospital, they can be given remdesivir, which is the antiviral therapy that was used quite extensively in the beginning of the pandemic, not used as much these days. but it's only IV. It cannot be taken orally. So you either have to get it in the hospital or in an infusion center that will treat patients who are actively infected with COVID. So those are, if you're under 12, unfortunately, the only option is to be treated with remdesivir because the other treatments are not available for children under 12. I will say if your child is not yet ill with COVID, but your doctors and nurse practitioners are worried that they're at high risk and they could become symptomatic, you can treat with remdesivir for 3 days rather than 7 days as an outpatient. That's an option in some places, and it does prevent admission to the hospital. That has been shown in adults. So the presumption is that would be the same for children. So these are the active treatments. I still think the best defense is vaccination, and in the appropriate case, Evusheld and other mitigation strategies such as masking. I myself, if I'm going into a very crowded indoor space, I've been to a few concerts recently. I will wear a mask. So masking is still a very good way to to prevent transmission. Um, so there's a question here about Paxlovid in those under 12. So it's not approved and can't really be given to children under 12 years of age. The dose is a standard dose, and it's only approved for those who are 12 and 40 kilos. So that concludes the presentation, and so I'm open to questions.
Awesome. Thank you so much, Dr. Foca. That was a great review and gave us a lot of information with some of the recent studies, also specifically with children with COVID infection and treatments. So we do have a few questions that came up in the chat. I know there were a few earlier. Karen, are you able to give me some of the earlier questions first, or okay, I can start with the one you have up here now, I guess. Um, are you able to pull that up again for us? This, I think. Or I can get okay. So one question was sildenafil is one of the medications that has interactions with Paxlovid. What are your recommendations for use of Paxlovid for patients on sildenafil?
So that's an interesting question, and I would say, the way I'm used to sildenafil use is for patients with primary pulmonary hypertension. They can't come off sildenafil at all. So if that medication is controlling their pulmonary hypertension, so in that case, I would say you couldn't use Paxlovid. In the rheumatologic setting, I don't. I'm not sure how it would be used. So
So it's a similar situation then with scleroderma, where they can have either pulmonary hypertension or it's also used for Raynaud's.
yeah, so if it's being used for pulmonary hypertension, I would say you really can't use the
And,
Paxlovid.
but yeah, with Raynaud's, there are other medications that we use. So I guess that would be on a case by case basis, at least talking with the rheumatologist from our side. Okay. And then, have there been any studies to track flares after or even mild COVID infections?
Oh, yeah. So in these studies that I spoke of, and I'm sorry I didn't put it up, but most of them did look whether the disease flared or not. At least in the single center studies. The database studies might have been a little bit more difficult, but in the single center studies, they did not see evidence that there were active flares with COVID if their disease was already under control.
Yeah, and I guess similar to that, we also get asked from patients a lot, even with the COVID vaccine, as far as risk of flares. So, what would you say in that situation?
What was that again? I'm sorry.
Risk of flare of their rheumatic disease after the vaccine.
Oh,
Um,
I think, well, that's a very good question. We haven't seen evidence of rejection in transplant patients. I would suspect that the number of flares after vaccination is relatively small. The amount of protein or RNA that's being given in these vaccines is very, very small. It would relate to the briskness of the immune response, probably to the vaccine that would cause the flare. But I would say for the most part, flares are a relatively small portion of post-vaccine side effects.
Perfect. Yeah, thank you. I know that's an area that we're still actively looking at within our rheumatology community. Um, all right. And next one we had was what are the current guidelines for COVID vaccination for patients with scleroderma or any rheumatologic disorder?
So the guidelines are similar to the general guidelines. So they should all have a 3-dose primary vaccine series, which is different than it is for most of us. And then if they're 5 and over, they should get the booster. So it's really no different. The differences are going to be how well people track the durability of response to the vaccine in populations of patients who are on immunosuppressive medications. So that's not something we normally do that well, to be honest. And we're really trying to look at it now in the transplant patient population. So it may be that in patients with active rheumatologic disease, that should be done as well. Yearly antibody titers to see if you still have titers to certain vaccine preventable diseases, and then boosting if those vaccine titers are low.
Sure. Yeah. That's really helpful. And I think for us to so just to clarify then, there is one extra dose compared to healthy children, correct? So they get 3 doses in that primary
That's
series
right. The schedule I
compared
showed was
to
the schedule for patients who are on immunosuppressive
who are
medication.
immunocompromised. Yes. Okay. That's basically, and that's will also the same recommendation from the American College of Rheumatology. So it's good that we're all kind of have the same message. Our next question is if after having contracted COVID, you notice your child's disease becomes more active, would it be recommended to increase immunosuppressive medications for a short time to calm the disease?
So
Um,
I would say that would be a conversation between someone like me, rheumatologist, and you as the family to go over stage of COVID disease in comparison to the flare. It may be appropriate to increase your immunosuppression for a short time, but if it's earlier in the COVID disease course, it might not be. So I think that's a sort of three-way conversation that has to be had.
yeah, and I can say from the rheumatology side of things, that's usually what's happening is we're working closely with our infectious disease colleagues to be able to make that decision. Um, okay, were there any other questions for us in the chat?
Okay. So I would just say to end that we are in a much better place than we were 2 years ago, a far far better place, and really some very simple measures, vaccination, which is we've now given hundreds of millions of doses of these vaccines. They have proven to be quite safe. And early treatment if your children are at risk for progression to make sure that they don't have to stay in the hospital.
Yeah, perfect. I guess to end, I'd also ask Dr. Foga, do you have, as far as other lifestyle recommendations for families? I know a lot of parents are still very nervous with their children on a lot of immunosuppressive medications. So we do still get asked that, from our parents of our patients. Do you have any other recommendations?
As in, homeschooling or
Well, school, yeah, I think just school and general, activities as kids.
yeah, I think that's a somewhat individualized decision, obviously. I would say that if there's a large increase in the number of infections, you may consider whether you're going to have your child mask in school all the time. You may consider whether you're going to have them school from home during the peak of the infections. So if we think that there are going to be a lot of infections this winter, that's a possibility. I would say going out to routine things should not be a problem, especially if they're outdoors. Obviously, the winter is a different uh, matter altogether.
Yeah. And I know we're going to discuss treatments, I think, in the next session, but we're hoping, I know you're comparing also in some of your studies with organ transplant, with transplant patients. So we don't think of our patients as being quite as immunocompromised. So do you kind of have a gradation on those recommendations? Do you?
Uh, no, well,
Or
not really. Personally, no. I mean, I think I make those recommendations for patients who are on immunosuppression,
oh,
and the families decide how rigorous or not they want to be.
perfect. Well, thank you so much for a very informative talk. I think all of us really benefited from getting that update. Um, Thank you, Dr. Foca.
Thank you. You're very welcome. Have a good afternoon, everyone.
Mhm. Bye.
Bye.